And we're live. It's 12th of July, 2022. How are you people? Welcome to the Sports Therapy Association podcast. My name is Matt Phillips, creator of Unchat Live, and your host for the last 108 episodes of the Sports Therapy Association podcast. If you are listening to podcasts, and thank you very much, just a quick, I'll mention it once and won't mention it again. Sometimes I feel like I'm going on too much, but do me a favor, will you just leave a nice little rating and a review. If you've watched a few shows and you like what we do, it's not a monetary thing. It's just so that our episodes appear higher in Google. So when we have these amazing guests on, which we do have, their good word will get out there much more if you can leave a review and a rating. So please do that if you're enjoying the podcast. Thank you. But you can join us live, which is what people are already doing, and they're flooding into the room now because we do go out live every Tuesday at 8 o'clock on the YouTube channel, because YouTube stays there forever. Facebook disappears. If you're marketing, Facebook's very limited. But YouTube is there forever. So Emma Wardle, regional rep for the STA, is in the room. How are you doing, Emma? Thanks for coming in. And what happens is when people do leave a comment, then I can bring it up on the screen. So if you're interested in that, go to YouTube and watch the live videos. Hey, Sabrina Monaghan, how you doing? Nikki Mansfield is in here. Yeah, and you can have a little look and you can see. Great way of networking, getting your questions to the guests. Oh, we are getting, something's caused a bit of a popularity. I'm not sure if it's Maddie or Ian, but definitely a little bit of a buzz out there this evening. Fantastic. And you're all welcome as well. You don't have to be a member of the Sports Therapy Association. You don't even have to be a sports massage therapist or sports therapist, any discipline. It helps if you're kind of like involved in soft tissue therapy, but I know we've got personal trainers who come along. We've got GPs. We've got all sorts of people who come along. If looking after people in pain is your game, then hopefully there's something in our episodes to help you. So that said and done, let me bring up my notes to remind me what I'm going on about. So if you do want to watch the video, then like I say, you can go to YouTube. If you want to listen to the podcast, then you can obviously go to your own preferred podcast app. If you want links to the podcast apps, if you're not that savvy with podcasts, just go to thesta.co.uk and you'll see there, if I bring it up on main screen, if you're watching on YouTube, no, actually won't do that, then you can see at the top of the sta.co.uk, you've got links for Spotify, Apple Podcasts, Google Podcasts, Pocket Casts. So even if you're not very savvy with podcasts, you don't know what's going to work on your phone, click them and it'll work it out with your Android or iPhone or whatever. Also, just a little shout out as well to the Women in Sports Therapy with our very own from the STA, Dr. Fiona Higgs and Deborah Thurlow-Rowley. They've got 4 episodes out now. The last one with Dr. Claire Minchell, who's a big friend of the STA. Fantastic. The Women in Sports Therapy kind of gives an idea of what it's all about. It's to do with anything to do with being a woman in sports therapy, but it's so much more than that. And I've kind of been pushing it that I even recommend that if you're not a woman, then you go and listen to it, because we've had so many episodes where it's kind of, if you're a bloke and you're working with women coming into clinic in pain, you need to know a little bit more than you might know because you're a bloke. And it's a great topic. These two, Dr. Fiona Higgs and Deborah Thurlow-Rowley, break it down wonderfully, really entertaining, been in the business for a long time. And they approach all of the subjects, not just of female pelvic health, but also anything about working in the industry, about discrimination, about some of the laughs, some of the tears. They share loads of stuff. And it's a real kind of eye-opener, which will help you work with your female clients. So do check it out. If you go to the sta.co.uk, you'll see that just click on podcast and the WIST podcast, which stands for Women in Sports Therapy. And you'll see a little link there to, I keep pressing the wrong button tonight. There we go. To follow us on Twitter. So they've got a Twitter media account now and also Instagram. So yeah, please go and follow them. Even if it's just the 5,200 STA people who like the Facebook page, that's fine. Just 4,000 of you go over there and follow them now. That'd be great. That'll do us a favor. Right. So where are we? We are in July and it's all about the foot and ankle. If you're new to the show, then what we're doing, or we have done all this year, is we pick a topic and we talk about that for the whole month. So word gets around, oh, they're doing like female pelvic health this month. Let's go to next Tuesday. I missed last week's, but let's go to this week's. Now we're talking about foot and ankle, and that's what we're going to be doing all of this month. Last week, we had the pleasure of spending an hour with Dr. Emma Cowley and Nick Knight. It was a great episode, again, because, I don't know, I just surround myself with lovely people. Maybe that's what it is. Such a nice way to listen and learn from 2 great names in the game. Some of the take-homes, and I appreciate all the emails that sent to me. Again, it's so nice, isn't it, to hear that somebody who's been in the business for that long is still evolving and still going to conferences and doing CPD and turning around to the patients and going, you know what, things have changed a little bit, actually. I want to try this with you, and not feeling embarrassed. And I'm sure that'll be a theme we talk about tonight, because things do change, which is a lovely segue into plantar fasciitis, or is it? So tonight, on the show, I'm exciting myself now with this lead up. It's getting quite dramatic. Again, two huge names. I'm really excited to bring you Maddie Tait and Ian Griffiths. Anybody who's followed me for a while will be familiar with Ian Griffiths, because I've known him far too long. He was in the first Run Chat Live conference in person down in Brighton, seated in a table, which is just like something out of, is it blasphemy if I say it was like the Last Supper? I don't know, but you had like Jesus, Simon Bartold in the center, and then spawning from the center, you had Ian Griffiths, and you had Jeff Asculia and David Griffin and Christopher Johnson, and it was just amazing. So I've known him for a good few years, and anybody who follows me will know that I've definitely shared his work an awful lot when it comes to the workings of the foot, particularly that word we're not allowed to say anymore, apparently, because it doesn't exist, but we might mention it later on. But and Maddie, I've had the pleasure of meeting and following for a while, and Maddie's going to be coming up as well. Maddie, I've read and didn't realize, actually played professionally herself in elite hockey. So we're going to talk about that a little bit as well, the experiences to share. And again, very experienced sports therapist, sports podiatrist, who works in conjunction with a lot of different professionals as well. So that's what we're going to do tonight. So sit tight, grab your notebooks. People still coming in the room, I will now bring up our guests for plantar fasciitis, or is it, Maddie Tait and Ian Griffiths. There we go. Good evening, everybody.
Evening.
How you doing? Thanks for joining us. I'm sorry that was such a long intro. It was 9 minutes. I promised 6, didn't I? But I just felt that you deserved a bit of a build up there. Ian, have I made you feel a bit old? We've known each other for quite a while, haven't we?
Correct. Yeah, I think I had hair when we met. You certainly had more hair than I see on your face right now. I know that.
See, I wasn't going to mention the hair. I wasn't going to mention it for the people who listen to the podcast. But no, you're a very handsome man with or without hair, and I've shared that information with you. It's not a surprise. But you're one of the giants. You're one of the giants, the shoulders who I have stood on. And it goes back. I should have found it, actually. I think it was a tweet going back to probably 2003 or something, where out of nowhere I was talking about overpronation, because I was fresh off an NASM, National Academy of Sports Medicine, and they were all very big on overpronation and this and that and tibia rotation, using that term. And then up pops Ian Griffiths, who obviously had his alarm set for whenever anyone on the internet says overpronation, and just appeared going, "Oh, Matt, have you considered this? Blah, blah, blah." And I was like, who is this man with loads of hair, very handsome man with lots of hair, challenging me on social media, which was quite unheard of back then. And then, you know what, after backwards and forwards, as always happens with people like yourself, it was like, we're actually saying the same thing. We're on the same side of the coin. And that just paved the way for me and made me very mellow when I came across other people challenging me. So thanks for that. That was about
pleasure.
17 years ago. Jesus.
Yeah, it was a phase I was going through, but I don't tend to go on Twitter as much anymore. I'm older, I've got children now, I've got less time, and also it's just become a bit more toxic. I think back in those days, I think I'm on reasonable ground when I say, you know, yourself amongst them. I met so many who I now consider colleagues / friends, who I've now known 10 years plus, and we all met on there disagreeing in a healthy and respectful way. And I guess present day, I look on Twitter now and then, and there's still disagreements, but the healthy respect seems a bit in a bit shorter supply. So I've backed away from it a bit now, and I let that term go more now than I did. I've chilled in my old age, I guess, is what I'm saying.
I can't work out whether social media's got worse or just we're getting older and grumpier and kind of looking at all these kids, why are they shouting at each other? I don't know. I can never work it out.
A bit of column A and a bit of column B there.
Could be. We need to ask somebody who's younger. Good segue. Maddie, how you doing? Thanks for coming along.
Hi. Thank you.
How do you find social media? Is it something you tend to stay with? Or do you still see
I love and hate it. I'm not committed to it enough to be on it regularly. Again, I guess busy lifestyles, and it takes time to prepare and add content, but I can see the value in it. It's just, for me, it's just timing.
I think life has changed. I think we're just busy and more stressed these days. Back in early 2000s, it was just a bit more chilled out. We had more time. You know, we could get a coffee for under £1.50. Nowadays, it's like break the bank, just have a frappuccino or something. It's crazy. So, but anyway, so thanks for joining us. Actually, Maddie, if we could start for people who haven't heard of you yet, especially people who are listening to the podcast, could you tell us a little bit about yourself and how you ended up being in the position you are?
Yeah. So I'm Maddie. I am a musculoskeletal sports podiatrist in London and Surrey. So I have a couple of clinics over the city and Southwest London and Surrey. And I guess I came into the profession knowing from an early age that I wanted to definitely go into the musculoskeletal sports side. I played hockey, field hockey. I represented England and had my whole heap of foot and ankle injuries. So therefore was exposed to seeing a musculoskeletal podiatrist in the kind of England hockey setup. And then from there sparked my interest in the feet and the biomechanics of the lower limb. So I suppose I didn't really come into it in the typical interest, which I guess from most of our profession is maybe more wound related, high risk foot care. I definitely came into it with my musculoskeletal sports head interest. So specialised in that from kind of as soon as I finished working. So I had a sports science undergraduate degree and then did a master's in podiatry.
Fantastic. So coming from hockey, I think it's fascinating. As someone who's worked with runners pretty much all in my career, now and again, hockey players have come in. And it's great because with a runner, it's like you say, so I don't know, you can look at someone's running, but it's not going to vary that much unless you're looking at really different biomechanics. But whenever I've got a hockey player again, well, can you show me what movement caused this or what you were doing? And they get down in these positions and these kind of clever twists. And it's like, wow, I can't even start to imagine, what's going on there. So
and then add a stick or a hard ball into the mix that adds trauma and all sorts. So I therefore had my very, very fair share of injuries.
Yeah. I'm just going to put up for people listening to the podcast. I'm going to put on the screen now screenshot of Maddie's website. So it's MT as in mtpodiatry.co.uk, and also on there just as well, if we just go to the next picture, you've got at least I think it's 4 or 5 episodes now where you have got guests, and one of those is plantar fasciitis. So if you don't fancy the show, then just head over to mtpodiatry.co.uk/podcasts, and there's a whole selection of podcasts there with Maddie. Is that something that you've wanted to do for a while, sharing the information?
I actually got invited on to be a guest for with a sports medicine doctor in London, and we just chatted through all sorts of topics about feet, shoes, running shoes, plantar fasciitis, so we just kind of split it up into some podcasts that way. But I am interested in it. It's definitely something I want to get into more.
Fantastic. It's good to see. Right. Ian, everyone knows you down there. Let's face it. Come on now. If you don't, people, and you're interested in the foot, then your first stop should really be Ian Griffiths. I'll put, just in case you've been living under a stone or just following some very strange people who haven't told you about Ian, then I'll put up a screenshot. If you start off by going to sportspodiatryinfo.co.uk, but also on Twitter, on Facebook, although Ian's not quite so much in an admirable way on social media so much, because I myself have pulled away as well. It's just toxic. And when you've got kids, you've got other things to concentrate on. There's still an awful lot of information out there on various feeds, as well as, of course, PodChat Live, whose name I just ripped off basically about 2 weeks after it started, and thought, PodChat Live, I'm going to do One Chat Live. There's a story there. They stopped at 99 episodes. We're on 100 and no, actually I stopped on 53 for One Chat Live. So yeah. But so that's worth checking out as well. 99 episodes of really excellent information if you're interested in the foot. Some of them obviously get pretty technical. Don't be scared by that. It's kind of a lot of podiatrists there, but there's an awful lot of information you can get, whether you're a massage therapist or sports therapist, or sports massage therapist, to check out. So Ian, do you feel old? I mean, I joke about it, but you've been in the game for a long time, and you are one of the names that people quote. I remember when Ian Griffiths wrote this. And there's articles which are probably written in the early 2000s. Do you feel old?
Yeah, I do. I wish I didn't. Every day, my body just reminds me how old I am. My wife says to me, because I'm still trying to put some reasonable running mileage into my body on a weekly basis, and still deluded that I can run PBs in my mid-40s when everything scientific and anyone with an understanding of biology and physiology knows your PBs may well be behind you by the time you get to my age. But yeah, I'm still deluding myself. But every day my wife says to me, you're always injured. And I say to her, no, I'm always in pain. I'm not injured. I'm just always in pain. And I think that's a really important distinction that I've convinced myself is why I can keep training. But yeah, I feel every bit as old as I am. And the crazy thing is when we've got, obviously I do a bit of teaching now, so we get the opportunity to see the next generation. And obviously Maddie's the next generation for me, and we've known each other for some time. We've met up for coffee and things, but there's another generation coming. There's always another generation coming, and I think it's amazing to see just how young and fresh-faced and enthusiastic they are, and what ideas they have. And I remember sort of being that sort of probably over enthusiastic 20-year-old who thought I had some great ideas, and I'd speak to people older than me, more experienced than me, and they'd be like, that's been done before, right? Almost everything's been done before. Whatever idea you've had, whatever discussion you're having, someone's probably had it somewhere before. And now I find myself on the other side hearing these discussions going on. So yeah, it's been a fascinating time. But yeah, I'm old and I feel it, but that's okay.
It's but then, I mean, once I had the pleasure of chatting with Dr. Benno Nigg, who kind of like go back from Ian Griffiths 20 years to 1986, was saying this word overpronation, or this kind of like this idea that, and it's like, and he's still banging his head against walls talking about things. It's crazy, isn't it? It really is. History just repeats itself. And well, it's only when you get to our age, you start realizing.
I thought I was being smart in 2003 when I wrote a paper on, that the idea, the concept that, and I know you probably spoke about this with Nick and with Emma, if with regards to the sort of the wide and completely normal expectation of anatomical variation. So rather there being one normal and then any deviation from that is abnormal. I thought when I was talking about this in 2003, I was being smart and at the pointy end of business. And I found a paper where someone in America said exactly the same thing, and they published it in 1909.
Oh wow!
So, there literally is nothing new under the sun, as they say.
That's crazy. Right, we've got to still stop talking about old days and reminiscing, because we've got to talk about here. Plantar fasciitis. So that's what we're talking about tonight. My first question to Maddie: are you happy using the word as a younger therapist? And we're not going to. It sounds really patronising. We won't mention age anymore, but as a younger therapist, are you happy using the word plantar fasciitis, or do you feel that therapists would benefit from looking at that name again, as some people do?
Yeah, I think we can move on from the plantar fasciitis, having a bit more of a global term, plantar heel pain, plantar fasciopathy, which can build on a number of different pathologies or presentations of plantar heel pain, is probably a bit more of a modern way of looking at it. And
we talked about this last week. What's up with the fasciitis then? What are some of the, because I can guarantee, and I'm not judging anybody who's listening to the podcast, but if there's a couple of thousand downloads, I can guarantee 1,000 people are going, whoa, what's wrong with plantar fasciitis? So what's the problem?
So I mean the itis end of it, itis meaning inflammation, and typically we don't necessarily see inflammation in the plantar fascia with a plantar fasciopathy. Coupled with that, it's often might not even be the plantar fascia that's involved. And I think when we, as all sorts of therapists, see a patient with a plantar fascia type injury or plantar heel pain, keeping the diagnosis quite broad to begin with, and management of it quite broad to begin with, isn't a bad thing, just to start off as we first see our patients coming in the door.
Okay, so this is really interesting. I want to dwell on this a second, because like we were talking off air, if a lot of particularly sports massage therapists, I'm sure sports therapists who've done university and postgraduates, they've gone past this point, but in the sports massage therapists, once you say it might not be inflammation, that then opens the door to, or maybe I shouldn't be taking ibuprofen. Maybe I'm not going to solve this problem with just icing. Maybe there's something else I need. So that's quite a useful door to open, I imagine, isn't it?
Yeah, absolutely. And I mean, at some point, we need to get a diagnosis, and the likes of imaging will be appropriate for some patients at the right time, and or onward referral to get to the bottom of it. But there's not usually, our patients don't present with a red inflamed heel, like you would if you bruised your leg and you needed to ice it and take ibuprofen. That's more of a visible sign of inflammation, but we don't see that at the heel. And even when we look at it at the plantar fascia on imaging, it typically doesn't present itself often as inflamed or thickened. So I think just thinking about the way we use the terminology is probably, like we've said about overpronation, similar with plantar fasciitis or plantar heel pain. It might be a bit more of a modern way of looking at it globally.
Excellent. We talked last week, I think it was, like terms like overpronation, I think, and a couple of other things. We said how some therapists just put the defenses up. It's like, oh, stop telling me to change my language. If I want to say it's a knot, it's a knot. If I want to say it's this or that, but it can have an implication. I think it's nice if you can reach that point where you do go, well, why should I be using this word? Because it does open doors. What do you think, Ian? Are we going over the top, or is it useful to change the term?
Yeah, I agree with what Maddie said. I mean, ultimately, you could take one view that whatever you call it, as long as you all know what you're talking about from a communication point of view, does it matter? But the crux of the matter is if a term itself bleeds into beliefs, and those beliefs are long-standing and we know them to be unhelpful in some way, then I think it's very reasonable to revisit the terminology. I think the itis osis thing is, people are probably familiar with the way that we've gone around the houses with that, with other tendon, not that the plantar fascia is a tendon, but we've done it with the Achilles tendon, for example, with going back in, some papers, you go back 20 years, we'll call it tendonitis, and then it suddenly changed to tendinopathy, tendinosis. So, it's a similar name change. I'm no biochemist by any means, but yeah, certainly the paper that I know, Maddie and I are aware of in the podiatry world that changed our thinking was by Harvey Lamont in 2003, and he was the first one to say, think of this as a fasciosis rather than a fasciitis. And like you say, the challenge we have, of course, is if we say to people, well, look, if it's not inflammation, you don't need to worry about anti-inflammatories. But on the flip side, we do have people come in and report when they do anti-inflammatory things, it helps. So that doesn't necessarily marry particularly well. But yeah, ultimately, I think, me, I think we do as best as we can until we know better. And if we do know better, then there's not really any excuse for hanging on to things just because we've always done them. There's not, I've never been a subscriber to that being the way that we progress as professionals, whatever our profession. So the way I'd often explain it to a patient would be, if you think about inflammation as being quite an acute process in the body. So, if you sprain your ankle, it's swollen and red and hot and angry. And Maddie's already said, we don't see any of that stuff with plantar heel pain, plantar fascia irritability. But even with a sprained ankle, we don't see that for 6 months. That inflammatory process is very, very acute. And then you get the more chronic problems that it evolves into. Like I say, most people that come with plantar heel pain, not only is there no visible cardinal signs of inflammation, but if they come in saying, I've had this for 6 months, 8 months, 12 months, and everyone listening will say, yeah, these are the timelines that people are presenting to us with. What sort of thought process are we thinking of where we say, this is inflamed, take some ibuprofen? It doesn't seem to marry particularly well.
Excellent. Yeah, great. You're both kind of using plantar heel pain a lot in your dialogue. So is that kind of a term which you're kind of happier using? You think it's better with a patient and allows you to look at it with a bit more open eyes?
Well, Maddie, I'll jump in, Maddie, if that's okay. You already mentioned this, didn't you? It was Henrik Reel and team's paper that they published in the BJSM that first. It was only fairly recently, a couple of years ago, in the big scheme of things, where they said perhaps plantar heel pain is a better term. So I mean, it's funny because I know for years we've always said we don't like the term metatarsalgia because that means that all that tells us is pain in the forefoot. It doesn't give us a diagnosis. And now we're saying we prefer plantar heel pain. All that really tells us is pain on the plantar, i.e. underside of the heel. So it feels like we're contradicting ourselves. But like Maddie says, and hopefully what the the theme that will emerge tonight is that not all heel pain is plantar fascia in origin. And I think we all know that 9 times out of 10, if someone goes to a GP or whoever and they say my heel hurts, it's more often than not they will leave with the diagnosis of plantar fasciitis or plantar fasciosis. And perhaps until we know for sure, like Maddie said, that's what we're dealing with, plantar heel pain is a better term in those early stages. So I must admit, throughout the talk, I will completely randomly and with no reason whatsoever be flitting between plantar fasciopathy, plantar fascia irritation, plantar heel pain. I basically mean the same thing, really. Yeah.
And often it's us who decides. The patient doesn't come normally going, I think I've got a case of plantar heel pain, although I prefer to refer to it as plantar. We're the ones who feel the need to give it a name, aren't we, and label it, and the patient just wants to get better.
Correct.
I think it's massage therapists in particular and sports therapists who actually legally aren't allowed to diagnose because we're not allied health professionals. You're not allowed to write diagnosis down on a bit of paper. You're not allowed to say to the patient, my diagnosis is no, not an allied health professional. Your insurance won't hold up if you've written that down anyway. So we're even more tempted to actually come up with a nice long Latin word, like I know iliotibial band is a great long word. We'll use that somewhere, or stick a syndrome on the end. But so let's imagine then a patient comes to us with the symptoms which formerly we would have said, oh, you got plantar fasciitis. So I suppose we're talking about really painful first thing in the morning, like walking on glass, these kind of metaphors and things that they come up with. Traditionally, we would have said, oh, right, yeah, it's plantar fasciitis, ibuprofen, some stretching. That always seems to be popular as well, especially with massage therapists, stretch everything. What are some of the other things we should be doing further tests on, which would help us actually home in on, one, whether we need to refer out, or two, whether we should be approaching it from a different point of view? Maddie.
Yeah. So I think it comes down to the first, well, in terms of me clinically, and still probably similar for you, Ian, but like all about that early communication. It's very much about that history taking and getting to the real understanding about when the onset of the symptoms were, how they manifested early, how it started early doors, maybe how it changed, because I think we see pain and the way pain stays in the heel, or it might move, or it might be at certain times of the day or after certain amounts of exercise. Getting to understand the pattern of pain, I find, is really important. And what maybe was around that origin, so or the onset, sorry, what changed? Was there an increase in running, in walking, in going back into the office after COVID and wearing a business shoe? What changed? And often I think with this sort of a plantar heel pain, plantar fasciopathy style, whatever we're calling it, there's something that happened. There's something that would have triggered all of a sudden. Every morning from now on, I'm now waking up with heel pain. And I think for me, that first 15 minutes of talking to my patient and getting to the bottom of that is the most important, to formulate where I then further my tests, whether that's an athlete, a runner, an everyday community member. Everyone's got a change in their pattern, and it could be volume and load related in terms of the sport, but it could also be walking around barefoot because we were locked down for X number of years and changed our footwear pattern, or got a dog and we started walking the dog more than normal. I think getting to understand that pattern really helps with the early kind of early thought process, if that makes sense. Obviously not a diagnosis yet, we haven't got onto any clinical tests, but definitely that thought process.
I totally agree. And as I already said, a lot of people that go to a health professional of any kind and say their heel hurts, they're going to be given the label of, oh, that's the plantar fascia. And let's be honest, if that happened to 100 people, that would probably be right more than it was wrong, because we know it's the most common condition that affects the foot. The thing that I think Maddie said that's so important about that, taking a good, asking right questions and taking good history is, for me, and hopefully what we'll come on to talk about more this evening, is I love the idea of people saying, okay, well, we know that it's the most common foot problem. We know it gets labeled a lot. We know that, even if we indiscriminately told everyone with heel pain that we saw they had plantar fasciitis, we'd be right more than we're wrong. But what about those ones where we're wrong? They're the ones that worry me. They're the ones that I think, are there things that we're missing that we shouldn't be missing? So plantar fascia pain or irritability is usually so typical in its presentation. Like Maddie said, you sit down and you speak to someone for 10 minutes and they tell you the story. And generally speaking, it's been sort of, they describe it as not having a cause. And what I mean by that is if when someone sprains their ankle, they normally say, they'll give you a date and tell you what pub they were coming out of or whatever it may be. Whereas this, they say it didn't really have a cause. It was insidious. But then, like Maddie said, when you dig a bit deeper, maybe it was interlinked with some kind of change in training volume or frequency or intensity, but it's still non-traumatic. So I think that's the key thing. If someone comes in and they complain of pain on the plantar aspect of their heel and there's no history of trauma, and they point to that medial calcaneal tubercle, so that underside inside aspect of the heel, and you say to them, how does it feel first thing in the morning? And they say, God, that's when it's worse. I feel like an old man or an old lady, but after a few minutes it eases off. That's such a typical story that I don't think it's unreasonable that you can then function under the provisional assumption this may well be plantar fascia origin pain. And I think if early on, if people could appreciate that, if that doesn't feel quite right, if none of that story, if there's parts of that story that don't fit, perhaps you say, okay, well, it is worse first thing in the morning, but they describe a traumatic onset. Well, that already you should have some alarm bells going off. So any history of trauma, which is a very simple thing to tease out of a discussion, any pain patterns that just don't seem to fit that really, really typical plantar fascia pain pattern, immediately they should be flags or bells, or your spidey sense should tingle, and you should say, this may be worthy of a few more deeper questions, a few more deeper clinical tests. We can come on to what those are and what they look like, of course, because we might not be dealing with what we think we're dealing with, and there are probably more sinister things that it's important to exclude right now.
Excellent. Really interesting. Yes, it's subjective. We've covered that so many times on the show. I think sometimes we just, especially that's the problem. Especially people who are fresh off CPD courses, and they're just so eager to get their hands on and start doing clinical tests and objective. And they're just, as soon as they hear one thing, they're like, I know what this is again. This is going to be myofascial. It's going to be like, so people don't pause to ask the questions, do they? Just let the answers come out. Brilliant. Let's move on though to clinical tests then. So imagine we've had this great conversation. We've listened to the patient. We've listened to them more. What sort of tests do you think people might be missing out? Well, first of all, I just got to say, sorry, Emma Wardle, graduate sports therapists can diagnose. Matt, that's very true. Okay, sorry. I was shoehorning you all into the same cauldron of not allowed to diagnose. I do apologize, Emma Wardle. Sorry. Anyway, but so let's move on to clinical tests. What are some things which people might not be doing which could help when we're suspecting something else is amiss here?
I'll jump in with one if it's okay, Maddie. And the one I'll do, and again, I'll do it in almost everyone just because it takes about 3 seconds. So there's not really a good reason not to do it. But I would definitely, it would be the first thing I reach to if someone reported some kind of traumatic onset, but also in the other parts of the history, if they reported pain patterns, like we said, that weren't typical, in particular night pain. So, there's the other flag, if people are writing notes, these are the things that really should get you thinking. I think if there was a traumatic onset or if someone reported night pain, a clinical test I would do almost immediately is what we would refer to as the calcaneal squeeze test, which is ultimately exactly what it sounds like. I tend to interlock my fingers like this. I don't even know how to. It's a podcast, so the video is not going to work. But interlock your fingers so that the fleshy parts of your palms are sort of either side of the calcaneum, the medial and lateral borders, and then just squeeze and be really, really quite firm. Now, again, we know that the calcaneus is the biggest and densest bone of the foot. It should be something that you should be able to put a fairly strong squeeze on, and someone should just say, yeah, I just feel like you're squeezing me. Anything other than that, you should be thinking, is there suspicion of bone injury here? If someone came in and said there was a traumatic onset, and I've had this before, when I've done a calcaneal squeeze test, they've physically withdrawn their foot from me. Sometimes they almost kick you in the face. Sometimes they shout a few swear words at you. You're like, okay, this consultation's over, because there's nothing else really we need to do here other than exclude the possibility of some kind of calcaneal stress fracture or stress stress injury. So I think night pain, traumatic onset, positive calcaneal squeeze test. You stop thinking plantar fascia, you start thinking calcaneal bone stress injury.
Brilliant. And that's typically one of those tests which, sadly, on a lot of syllabus or syllabi, they're kind of like, there's 25 of these tests, and the more experience you get, the more likely you are not to bother thinking, because you're not going to see them that often depending on what population you work with. But like you say, they've got to be done. It takes 3 seconds, and it was one of probably the other 19 tests you learned you don't need to do anymore. But yeah, all of them, because if it is positive, like you say, then what would be the how would you follow up then? Is that then referring them off to somebody who can?
Well, I guess it depends
or something. Or?
Yeah, well, I guess it depends on your setup and where you work and your support. Whether you've got an interdisciplinary team around you. But ultimately, I think the point here is, if you have a raised index of suspicion for bone stress, you don't treat it like you would a plantar fascia pain. So your plans for whatever your plans were, and they may have been soft tissue work on the calves, they may have been acupuncture, that whatever they may have been, which may well have been valid for a plantar fascia pain. With the raised index of suspicion of bone stress, you've got to park all of that. If you've got the opportunity to get them in a boot, an air cast boot, if you're in a clinic which has that's, you go straight there and then you send off for kind of imaging, probably MRI ideally, to confirm the diagnosis. And like I say, good management is dictated by knowing what you're managing.
Fantastic. And obviously, I suppose it's going to affect when they say, "Can I still go running? Am I allowed to still do skipping in my backyard?" It's like,
well, it helps you. It helps you set expectation of timelines, prognosis, but also it often, we're runners. Like I said, I'm in pain every day. I've run with heel pain before. Like, if something hurts, it doesn't stop us running until it stops us running. If that makes sense. Until you tell someone they've got a fracture. And actually, all of a sudden, even runners, even triathletes, in the crazy wired way that we are, that diagnosis, and at that point, it is a formal diagnosis. Not only does it help you set expectation and management and timelines, but actually, all of a sudden, you watch how well they'll comply to dialing back on the load. It will be immediate. Yeah.
Maddie, you were going to say?
I think just based on what you were saying about kind of getting that next onward referral, I think having, as massage therapists or sports therapists, needing to go down that kind of next intervention or get some more imaging, I think Ian and I are lucky we have colleagues that we work with closely in the same building and we can call on when we need to. But I think that does have a massive element of comfort when it regards to kind of managing our patients. And if you can get a good doctor, sports doctor that you can have on hand when these things do creep up that you're not sure of and you might want to discuss, or a good local podiatrist or physio that you can bounce something off, I really think that it can help. I think especially early doors in the profession. And I just certainly have called on expert colleagues in the past when I'm not 100% sure on something. You get that feeling, like Ian said, you get that kind of red flag, something's not quite right, but I'm not sure, but the patient's lying here. How do I manage this? What do I do? Do I tell them to leave? But what do I send them? You know what I mean? It's just, I think having that communication with maybe another colleague might be helpful. And you know, the patient's going to prefer you to be honest and say, I'm not 100% sure here. I'd prefer to send you out the door. I'm going to kind of try and communicate with someone that I think might be able to manage this better or more appropriately. I'll get back to you. I think there's no harm in doing that and managing expectations there.
I think it's important not to be worried about being wrong as well, just to add on to what Maddie said there, because I think people are worried, what if I refer on and they think I'm silly because it isn't a stress fracture? Well, here's the thing. If you've got night pain, traumatic onset, positive calcaneal squeeze, any one of those, by the way, would be enough for me to have my flags. I don't need all three. Any one of those, I'm thinking this may be worth further investigation. If you're going to be wrong, you would much rather send them on to someone and then say, this isn't bone stress. That's a better wrong than holding on to them and massaging their calf for the next 4 weeks under the illusion it's a plantar fascia and it turning out to be a bone stress. Like, we're all wrong at times. I've sent on things that I would thought this is a barn door stress fracture. And I sent it and I said to the patient, this has all the hallmarks of a stress fracture. We have to know for sure. It completely dictates what the next 6 to 8 weeks look like for me and for you. We sent them on and it wasn't. And the patient, the referrer they didn't tell me that they thought I was silly. The patient wasn't upset with me. No one's time has been wasted because you've still got more information than you had before. So I think it's really important if you're, we're never certain clinically about anything, but you have a raised index of suspicion, and don't be afraid to be wrong about it, for sure. But it's just important that we don't miss these things. That's important. Or even if there aren't, I would always say, even if there aren't some of these flags and you're treating it as a plantar fascia and it's just not responding in the same way that they normally do, or you just think, oh, this just doesn't seem to be responding to treatment. Like at some point you need to be reevaluating. Do I just keep doing what I'm doing, or do I need to revisit another avenue of possibility here?
Excellent. Great message. And we mentioned a few times, a lot of our listeners probably are working in the clinic by themselves. It's lovely. I grew up in a multidisciplinary clinic, so it was amazing, especially when I was junior, and I would shove everybody to the physio or the osteopath or the podiatrist if I was unsure. But then eventually you start realizing, they send them back to saying, Matt, you're doing fine. Just keep doing what you're doing. I would do exactly what you're doing. But like you say, there's nothing wrong with it. No one's embarrassed. The patients are happy. But when you're working by yourself, you've got to have a bit more confidence, haven't you? Because there's this fear that they're not going to come back to you. This is where you can be multidisciplinary, even if you're separated physically. You're just at the end of a phone, and
And I think there's no harm in reaching out to a local colleague that that works down the road, that you maybe pop in one day and just hand a business card over and just say, look, if I get a patient that I think might be foot related, that I think I'd be really grateful if you could see, or likewise vice versa. I think I'm a podiatrist and I've got patients that actually are really tight proximally. They could work on some sort of stretching and hands-on work and strengthening. Likewise, I'd send to you. So it's kind of a two-way thing, and I think people are really responsive to that. Just go and contact people. I don't think there's any harm in that.
Very cool. And they may well pay people you refer on, may well send more work your way, because they know that you're going to spot stuff and look out for stuff. Like you were saying, Ian, in your practice in Canary Wharf, still in Pure Sports?
Yeah. Yep.
You've got a massage therapist there who's just like A1, brilliant at recognizing stuff. You feel really confident, and she will put people your way if she starts seeing alarm bells going off. Good therapist. Absolutely. Good therapist. It's exciting. So go on.
Sorry. No, I was just saying, I think for me, when you're thinking about sort of, the title of this episode being, not all heel, I can't remember what you called it. It was something snappy, but not all heel pain is plantar fascia pain, or whatever. Something's cooler than that, I know. For me, we should probably say, in the limited time we have, there's the list of differentials, for heel pain is massive. So, we've picked on calcaneal stress there because I'm not saying it's the most common differential, but I certainly think of probably the 2 or 3 differentials that we may have time to cover at most. I'm not saying we're going to pick the most common ones, but I think we should probably spend time focusing on the ones that are important to exclude or not miss, if that makes sense. So I'm not saying you're going to be seeing a lot of calcaneal stress. We see some, but I'm not saying in your clinic tomorrow, if 4 people came in with plantar heel pain, that you'd expect any of them to be calcaneal stress, but you'd also want, it's the one that, even though you don't see lots of it, you want to make sure you're excluding it.
Fantastic. Okay, well, with that in mind, let's move on to number 2 on the hit list of other possibilities. What else would you be doing?
What do you think, Maddie? I was thinking neural. Yeah. I mean,
something stemming from somewhere else that's presenting itself as a heel-like pain. Obviously, our anything back related, and how that creates a radiculopathy down the leg. I guess linking into the kind of neural aspect, doing some neural testing.
Going back to subjective then, what sort of things might have started you thinking along those lines?
History of back injuries. I've had a disc problem since I was, however old. A bit of trauma, a fall, a trip, that definitely was back or glute related. Gluteal tendinopathies that's kind of creating a bit of a sciatica effect. A bit of numbness, a bit of pins and needles, any sort of sensation type words that are coming out. I think I would be thinking kind of neural.
Yeah, I agree. I think it comes back to what we said earlier, in that plantar fascia on paper is so typical This is why people, when they've Googled it, they say, I think I've got plantar fascia, because they've Googled it and they're reading a list that just sounds like them. So as soon as something doesn't sound like that, and nerve pain, whether it's a lumbar radiculopathy, like Maddie said, or even a more local, like tarsal tunnel syndrome, nerve pain, anyone that's experienced nerve pain will know it's weird. And it's definitely, we often, if you say to someone, with a tendon problem or a muscular problem, when's it good and when's it bad, they can normally chart out a 24-hour pattern and tell you what provokes it activity wise. But nerve pain, it's a bit unpredictable, a bit erratic, a bit inconsistent. Like Maddie said, they report numbness, tingling, paresthesia, radicular leg pains, pain that sounds weird, shooting, sharp, etc. I think you're always kind of thinking, okay, should I be considering neuro? And again, just like I would calcaneal squeeze test everyone, I would also ask every single person that came in with heel pain if they have any history of lumbar spine issues or radicular leg pain. And I'd probably do a neural provocation test, either the slump test or the straight leg raise. I would do that on every single person that came in with heel pain. And they're super, I'm sure most people listening probably know these tests already, but maybe they don't do them for everyone that comes in with heel pain. Again, it takes another 15-20 seconds just to really confirm that you've excluded calcaneal stress. Now you're excluding neural or radicular leg pain.
I'm interested, people are listening on YouTube, just drop something in the comments. You're going a bit quiet in there. You got your notepads out again and your biros, but yeah, let me know, are you habitually doing slump tests if somebody's coming in with heel pain and there's a history there, or has that kind of disappeared now and you're flashing over it? I'm interested to know. Write something in the comments.
I think asking about lower back pain is a question that I ask in every single consultation. I don't know about you, Ian, but yeah, I might be presenting a very foot-related injury, a big toe joint pain, sesamoiditis, a forefoot injury, whatever. Every single patient I will ask about a history of back problems. I just think we see such a correlation between lower back neural presentations, even kind of musculature tendon injuries, and that can change how people are functioning and moving and walking. And are we seeing a gait compensation effect? Is this all one-sided? I just think that communication is so key, and it takes, again, 30 seconds. Most of the time it's no back pain, but when it is a constant back pain and it has been there for a long time and it isn't getting better and it doesn't respond to X, Y, and Z, I think that's when alarm bells can start thinking. But it's just a quick easy question about lower back, previous injuries or current injuries.
Fantastic, great stuff. Moving on, next. I'm putting you on the spot here, just going to rattle off what else you think it could be.
I think as well, like just the location of where we're talking about in terms of the plantar fascia and plantar fascia pain, and or I guess we want to be ruling out any sort of tear in the fascia itself. Patients aren't going to want to respond to much hands-on work if we've got a fascia tear. I think that comes, again, it can be quite a local specific pain, and if often with a more fascia related pain, it's not necessarily a tear, it's quite local to that medial insertion on the calcaneus, but it can kind of change around the foot, and I often find people will say their pain moves around a lot, but if there's a tear, it's usually a very local pinpoint area of pain. And when we do kind of dorsiflex the ankle and the toe so that the band of fascia is really at its kind of tightest, that's when people will usually find it very uncomfortable, but also really pinpoint areas of discomfort. So that's usually quite an area of a test I might do.
Yeah, and kind of just to add on, totally agree, but just to add on, in all the tears I've seen over the years, you normally have a suspicion, but it comes back to the history taken. I know, but plantar fascia tears are very rarely insidious. There's normally a story.
Oh, he just left us momentarily. That's okay. It's been an internet surge, or Gremlin's got in there. You're going to have to continue. I was going to say, but in his voice.
I think that,
No, don't do that.
I think what you're saying is history, and if there's been an incident where I was out on a run and all of a sudden I got this sharp shooting pain in my arch of my foot, then I that's not a typical plantar fascia or plantar heel pain related injury. That might just be plantar fascia in origin. I think just ruling out a tear. I think it's much more acute. Oh, hello.
Sorry.
I don't know what happened there. Could have been you or me. I don't know. But Ian's back in case you.
I just
Maddie
carried on
finished
saying that
yeah.
I think you were saying that it's history and often quite an acute specific movement pattern or injury that might have caused it.
Yeah, the history will raise your suspicion again. So it generally comes back to that, doesn't it? But yeah. Sorry for I don't know what happened there, but yeah, I was saying all of the ones I've seen, there's always been a story attached to it. You know, the last one I saw just recently, because it's fresh in my mind, is someone who's a competitive in taekwondo, and they felt something as they on the standing foot as they kicked, as they twisted, they felt something go. They usually use terminology like they felt popping or going, so that would raise your suspicions of local tenderness, like Maddie said, but also that more traumatic story rather than a more insidious onset.
Yeah, I think one other that's fresh in my mind, because I've just done a presentation on it last week, is Planta Fibromas. And how they manifest in the foot, which are hard lumps that often are in the plantar fascia, often the medial band of the plantar fascia. And they present as hard, firm lumps, literally there, and they're very tender to touch. And if you see one, you'll notice it and you'll see it again. But I think, again, that might be something that we need to get looked at in terms of either further imaging or management, and they're not often actually managed too well with any kind of hands-on work, because they're usually benign lumps that can grow and change in shape and size, and often the management is sort of offloading of the lump itself, and management of that. So I think that would be, if you haven't seen one, I think maybe just go and have a look at what they look like and how they present clinically. But yeah, plantar fibromas. Or do you see much of them, Ian, generally? And
again, not lots, but when you see them, you see them, and patients often come in because lumps tend to worry people. And like I say, we would always ultrasound scan them, and we had a few that have responded quite well to steroid injections, and we got a few that surgeons wanted to get hold of, and then you get nervous about surgery around the medial band of the plantar fascia. But again, it is something that if you're working on someone's feet as a massage therapist and you feel like lumps and bumps down that medial band of the plantar fascia, just be mindful that it could well be a fibroma, and they're not always painful, and if they're not, just leave them be. But it is a quite sensitive tissue, and when they get irritable, they're quite difficult to offload.
It is really frustrating, and I'm sure you guys have had this, both being active on your feet a lot, but when you have got heel pain and then you do press in and you find that kind of thing that's different, and you think, was that there before? And I went to Nick Knight myself as well, because I was suffering from something, and I didn't pay much attention to the fact that I'd taken up 2 months of running with a weighted vest and 12 kilos on me, that maybe that was a factor. Forget that. It was like, but feel this. Can't you feel this? What is it? Is it a heel spell? What's going on there? I can feel it, and it wasn't there before. And it's so tricky, isn't it, for patients when they do start self-analyzing and they find something, they think that's it, and they'll start prodding it and poking it. And how would something like you just mentioned now differentiate on palpation from a heel spell or something that was just anatomical variety or something that you don't have to worry about? How would it present itself that made you start thinking that it could be that?
What, a fibroma compared to a heel spell? I think the fibroma is typically a little bit further away from the calcaneus, so they're actually more in the medial band of the plantar fascia. They're not hard bony lumps, they're fibrous-y,
squidgy.
They're mobile. Would they move around a little bit as you're pushing on them and you feel them kind of shifting, or
little bit,
not like a ganglion would,
no.
But you'll feel like you can move it. But if it's soft and squidgy, and it's more in the medial arch really, than it is back at the heel. So if it's soft and squidgy and in the medial arch, and it feels like it's part of the medial band, it may well be a fibroma, and then you can get those referred on for sure.
Okay, fantastic. Well, we've got some people commenting on the slump test seem to be popular. We had a few comments here. I'll come back to Becky's fantastic question. It's Becky question time. Leslie Campbell says here, Nope, slump single raise wouldn't be a go for me with heel pain, to be honest, but will do from now on. Good on you, Leslie. Nikki Mansfield said, haven't done a slump test for a while. Admittedly, wouldn't have really thought to do one for plantar fasciitis presentation. So thanks for pointing it out. There we go.
Great.
So time goes so quickly, especially with people like yourselves here. I've got a question here from Catherine, or Catherine Reimer says, I've had clients before with Morton's neuroma. I've had something similar, which is uncomfortable.
So on that, just to jump in, sorry, Matt, you know the way people describe Morton's neuroma pain. So you often say to them, what does it feel like? And they'll say sharp, they'll say tingly, they'll say radiating. They'll sometimes say it feels like my socks bunched up, or it feels like there's a pebble in my shoe, or, basically these kind of descriptions, are kind of nervy type of descriptions. They're weird and they're nervy. So anyone that's coming in with heel pain, but they're saying those kind of words, then if you're not slumping or straight leg raising already, then that should go to kind of further strengthen your hypothesis in that regard.
Yeah.
Fantastic. Becky Carroll, going back to Becky here, says, maybe jumping to conclusions here, but I've noticed a link between patients taking statins and heel pain. You come across this link before?
So this is a wonderful question or comment for a couple of reasons. The first thing to say is I don't know of this link, unless I don't know. Jump in if you do, Maddie, if you know different. Obviously, there have been links to statins and tendinopathies before, in the same way that they have the quinolone antibiotics. But I think what the deeper layer here is that if someone's taking statins, then what we're now talking about, and we're going back to the history taking again, is the questions that we should be asking during a history taking, the wider questions about their general health, the presence of any potential systemic or metabolic conditions. Because as we know, like heel pain is a common presentation in quite a lot of arthropathies. So I think the last thing I read was 10% of people with psoriatic arthritis report a manifestation of heel pain. So although I feel like I've possibly taken Becky's question and molded it into something else, another thing we should probably say is, because it doesn't take too long when we're taking our history taking, we're asking about history of back pain and what the pain feels like. It doesn't take a few minutes to say, how's your general health? What medication are you on? That gives you a bit of an idea of what's going on systemically, inflammatory, metabolically. And then you can ask about family history, which I think is important, family history of arthropathy and things like that. But also then our inflammatory flag questions, which would be, do you have any regular gastrointestinal disturbance? Do you have any regular eye irritability or irritation? Do you suffer with psoriasis? You've probably gone through this on the previous episode with Jack, I'm sure, the rheumatological flags, the inflammatory screening questions. Because if someone comes in with heel pain and you get a few yeses to those questions, do not exclude that this may not be plantar fascia pain. This may be another manifestation of a more systemic metabolic state, if that makes sense. So I think if someone's on statins, it would maybe set off your senses that if you haven't asked those questions already, I better go back and ask some of those questions to get a bit of a wider picture.
Excellent. Yeah. It was interesting. I remember Dr. McCowley saying last week, like, don't forget that runners get systemic diseases as well. So sometimes I think the danger is, someone is training loads, they're trail running, that they're that sort of personality. So you automatically presume that it's some degenerative kind of thing, which they've been accumulating over the years, and you forget about something which could be like this.
And also if a male in his mid-40s came in and said, I've got pain in both my Achilles and both my plantar fascia, and you said, okay, talk me through what your volume looks like, and he says, I'm an accountant, so I sit down all day, but I run 90 kilometers a week. It's not unreasonable for you to just completely go, well, of course, we've got overload. This is a classic load capacity mechanical overload problem. But actually, male in his mid-40s with pain in more than 3 sites, immediately go to those inflammatory flag questions, even if they're a runner. I mean, if they weren't a runner, if someone came in their mid-40s and said, both my Achilles tendons hurt, both my heels hurt, what do you do exercise-wise? I don't do anything. You'd be going, okay, well, do we need to ask for a rheumatological opinion or take some blood? Well, whether they're a runner or not, like, they're still a man in their mid-40s, who metabolically, we know they can, things like ankylosing spondylitis, they can manifest later in life. So you ask about the flag, but you also ask the family history is key there as well.
Yeah. And I think as well, it's like taking what the patient says with a pinch of salt, because that runner Ian's just mentioned could have mentioned about his increase in running load, and And automatically, I think maybe you start going down that train of thought. But actually, if we think about the history further and we ask those questions, and then we make our own decision up, I think that's a much better way of kind of managing the further tests and questions thereafter. Whereas sometimes I think they come in and say, "Oh, I've got this. I've been told I've got this, from Google or whatever," and then you just want to make your own clinical test and clinical mind up about what you're dealing with.
Very interesting. Oh, it feels like we're just getting warmed up now. Feels like this is where, I'm going to have to turn this into 90 minutes. That's fantastic. I mean, we are at 9:02, people. Thanks for those questions coming in. Before we do go, though, because I feel there might be one more that you're burning to say. Do you think we've mentioned a few now? Is there anything else in your experience where we should keep an open eye? Or
well, I don't know what Maddie's experience is. I'd be interested to hear, but a lot of referrals that end up with us may well come from other health professionals that don't particularly enjoy or like feet. I don't think that's an unfair thing to say. They're not for everyone, which is fine. I certainly know that we'll get some people come from GPs and the GP didn't even ask the person to take their shoe off. As soon as they heard they had foot pain, they said, go and see the podiatrist. It's probably plantar fasciitis. Now, the reality is if someone goes to a GP and says, I've got pain in my heel, and they say, oh, it's probably plantar fasciitis, go to the podiatrist. By the time between then and when they see us, they've gone online and Googled plantar fasciitis, and now the ball, the snowball is gathering size, and the avalanche is about to happen. And actually, I've seen people come in, and obviously, when we say heel pain, it could be posterior heel pain, it could be an insertional Achilles problem, it could be. I've seen. To think of the last 5 things that came into my clinic that came in as I think I've got plantar fasciitis opening statement from the patient, or I've been told I have plantar fasciitis. I've seen Achilles tendinopathy, posterior ankle impingements, tibialis posterior tendinopathy, subtalar joint synovitis. I mean, because all of these give you pain in that region. And if the first person you see just sows the seed that it's the plantar fascia, that's the road you're off on. So this comes under. When we talk about sort of neural and calc stress, they are people that come in with symptoms, and the rheumatological. They are symptoms that could very well manifest a bit like plantar fascia. But a lot of things that get labeled plantar fascia, when you actually speak to them properly and poke and prod and assess them, it looks nothing like plantar fascia. It's just pain somewhere in the rear foot. I don't know if you get similar, Maddie.
Yeah, absolutely. And it's rarely the plantar fascia that's actually stressed, but as soon as you start doing further tests and questioning and getting people moving and asking when they get their pain and doing single leg exercises and balance work, the amount that you can get from that, I think, can really change. So, I would say it's rarely just fascia related, and I think that's what this whole kind of mentioned from the start, really, isn't it? Is not often plantar fasciitis. It's probably not anything, might not be plantar fascia related, but just having that open mind about what other. Not forgetting
the fat pad as well. We haven't mentioned the calcaneal fat pad. We should probably mention that, because that can be really miserable when that gets, fat pads are so highly innervated, and when they get inflamed and it's underneath the heel, it's a bother every single day. And the irony is, these are the people who may well complain more of walking than running, depending on their running foot strike pattern and technique. But one test we often do for people, and it's not necessarily diagnostic, it's more just for sort of more information gathering, really. We will often say to people, or we'll get them on our treadmill in our clinic barefoot, and we'll start walking them, and we'll say, think about when it hurts during your gait cycle. So, and even say now. And what you'll find is that one group, there'll be a subset of people that will, at heel strike, every single heel strike, they'll say now. And there'll be another set that it will be more sort of late mid stance propulsion as they're pushing off. So what we have rightly or wrongly sort of hypothesized is, well, if you hurt more at heel strike, then it tells us that compressive forces are more problematic for you or provocative for you. But if your heel's off the floor, if you're getting pain back at the heel, but when you're at propulsion, at toe off, then it suggests that it may well be more tensile forces that are provocative. And these are both plantar heel pains that you may treat a bit differently. So when you speak to your friends, the people at the running club, and some people say, oh, I bought those silicone heel pads from Amazon, and they were just magic. High chance if you did really well with those, you were probably the person that was complaining of compressive provocation. Because if you have got tensile provocation, when your heel's off the floor, the pad can't help you. Whereas the people that say, I bought a pair of insoles off of Amazon, or I taped up the physio taped my foot up, and that really helped, then it may well be more of a tensile provocation. We do treat those things kind of differently. So that's another, I guess, tool that people are going to add to their questioning when they're asked about night pain and rheumatological flags, and they've slump tested them and calcaneal squeeze tested them. Also, sort of say, when does it hurt them? You've told me where it hurts, but when does it hurt? And I don't just mean when in the day. I mean when in the gait cycle, because actually that may make you think, okay, this person probably their sensitivity will settle down if they just get some cushioning under that heel, or maybe they might need a bit more.
Excellent, really good. Yeah, one of the best tests is just do something that causes you pain. It's like one of the best tests in the book, isn't it? Get them to do it.
Sadists that we are.
yeah. Well, we can sit back.
And then I guess it's just managing how it changes. So if you're seeing them every week and you tell them to go and change your trainers, and they come back and they're like, oh yeah, it's made a massive difference, then it's still management, because it's probably not gone in that week, and it's still a case of managing it. And often it's actually that cushion didn't make a difference, or that insole I bought on Amazon didn't make a difference. Now what? And there's loads of little, tricks and tips that we can all try, and taping, and like Ian said, change of footwear and insole, arch support, cushion, gel, whatever. But I think there's lots of, and speaking to maybe a local podiatrist if you want a more of a device that might be appropriate from a kind of mechanical insole orthotic, type input. But just, I think, continue that communication. And as Ian, I don't know if you're the same, but like often if we're not sure what it is and we're going down a diagnosis, and we are trying to change that loading pattern or change the forces that are coming from the ground up. Oh, my laptop. The likes of taping and footwear would often be my first line intervention anyway. And if a patient's already tried that because their therapist has recommended it, and then they come to see the likes of us, having tried X, Y, and Z, it makes our management plan that next step on from any sort of further tests. Or
I think that's totally, not only is that totally reasonable, it's in keeping with the best practice guide that was published in the BJSM just last year, which, for those that aren't familiar, and I'll really quickly summarize it because I know we're short on time, but it was a huge piece of work that pulled together a systematic review. So essentially all of the previous science that had told us what works and what doesn't work for heel pain. That was one arm of it. The second arm was interviews with world-leading experts who treat pain. What do you think? What are you seeing in your clinics? What works best in your experience, in your hands? But then the third arm, which is really important and is often left out of medicine, was the patient experience as well. So the people that actually suffer. What do you think helps or doesn't help? What would you like more of or less of? And then this work sort of tried to pull all of this, the science, the experts, and the sufferers, pull it all together, synthesize it, and spit out a bit of a, not a recipe, but I know that's what we all want, but a bit of a guide as to say this is a very reasonable way to treat heel pain in a sort of staged process. And what came out of that is exactly what you say, Maddie. Early first line interventions of tape, stretching, and education, which is pretty much what we've talked. Education would encompass footwear, it would encompass load management, etc. So taping, stretching, and education were the first line strategies. And again, once you think this is, you've excluded all the sinister, of course, that obviously goes without saying. And then the next things after that were the things that you'd refer on for. And the two rather strong things that emerged were shockwave therapy and foot orthoses, which obviously, depending on whether you've got access to those or you're happy prescribing them, you may need a referral network to do those. But I think everyone can tape, stretch, and educate. Everyone can exclude the red flags, exclude the sinister, tape, stretch, educate, and then you've got a really good working sort of pathway to sort of not just adhere to, but know that you're being evidence informed as well.
Excellent.
That's open access, that paper as well. So I can,
we'll put a link to that in the show notes, and that'll be very interesting reading. Okay, right. Well, look, as Nikki says so eloquently, an hour is never enough. It's so true, Nikki, in so many aspects of life. Becky Carroll, thanks for joining us. People who joined us live. Becky Carroll says, thanks, Maddie and Matt. Fab chat. Leslie Campbell says, very good chat, lots to go and utilize. Thanks, all brilliant. Huge thanks if you do join us live. I know it's such it's so nice to have people joining us live, giving up your time, but also it's so nice to have people of your caliber joining us. There's so much in there. It's again one of those ones I want to listen to. So thank you, Maddie and Ian, for joining us. It feels like there needs to be a part 2 at some point, because we really were just getting warmed up. There's so much, but then there's no surprise, is it? Like they said last week, the foot is a complex part of the body. They're taking great pride in that. It is. And other therapists do fear it, and it's probably right to have a little bit of that. Maybe fear is the wrong word, but just to know when to refer out, because it is complicated and complex, and the more you generalize, the more probably you're missing stuff. So
I always say it's like the sea. Don't fear it, just respect it and know that you don't fully understand it. That's a reasonable way to approach the human foot, I think.
Oh, it's beautiful. What I'm going to do for the podcast version is I'm going to cut there and just have sounds of waves going and then coming back again. I'm going to do an edit of that. That's amazing. That's so beautiful. Right. Okay, guys. We have come to the end. Just before I forget, a little bit of housekeeping. Dun, dun, dun. COVID cases rising. We have to do it. It's happening. It's true. Both in therapists, I know therapists, we know patients as well. It is happening. Cases are on the increase. Doesn't mean immediately we're all going back to masks and getting worried and stocking up on whatever it was, pasta and toilet paper, but it means that as healthcare professionals, you do need to be checking that your risk assessments are up to date and you are thinking about risk that you're posing by seeing patients. Especially if you're an STA member and you've got any questions, then contact your local STA rep, or as always, just email admin@thesta.co.uk if you're not quite sure what you should be doing. But yeah, definitely there's definitely a big wave happening again. So your duty to look after yourself and the people who are coming into your clinic. Don't want to end on that note. It's a bit of a downer. Sorry about that. But we will be back next week at Tuesday at 8 o'clock. We're going to have James Earls with us talking about the evolution of the foot, which Emma started. I mean, Emma, you've just spent some time, haven't you, with Emma, Ian? I could spend so much more time with Emma. She was amazing. She started going into, well, apparently it's not as clear cut that hominids came down from the trees now. It's more a case of they started showing. It's like, wow, let's just talk about this. It was brilliant. But it's a fascinating area. We'll be doing that next week with James Earls, who a lot of you have got a lot of time and affection for. He's going to be coming and talking about that, the evolution of the foot, which is going to be great. But I think that's it for now. So once again, thanks to Maddie. Thank you for coming along.
Thank you very much. Thank you.
Brilliant. Thanks for joining us. And thank you to you, Ian.
Pleasure. Thanks for having me.
Love to spend time with you guys. And yeah, thanks everyone who's joined us. And if you listen to the podcast, hope you enjoy it. Leave a rating and a review. And if you do want to join us live, then it's 8 o'clock on Tuesdays on the Sports Therapy Association YouTube channel. That's it. Take care, people, and we'll see you soon.